Good evening, friends. Welcome to this Tuesday evening webinars from Yashoda Group of Hospitals. We try to bring some topics which are of interest to the clinicians and which are the burning topics of that particular time. So in this week, we thought the last couple of weeks, there is a surge in fever cases in the city of Hyderabad and also across this part of the world. So we have seen many families getting scrambled with these fever cases, school children dropping from schools, and the OPDs has shown a surge. In the city of Hyderabad, the Fever Hospital, Nizam's Institute, and other medical colleges also shown a surge in the fever cases in the last couple of weeks. The same kind of pattern has also been noticed from the hospital group Yashoda here. So today we felt like we will bring some interesting topics, like we have seen a mix of fever cases and some of them being a tertiary care unit been referred to us in a complex city. So we felt our senior medical faculty from the Department of Internal Medicine in the Yashoda Hospital, Hitec City. We have 4 senior clinicians who will actually bring us some light on this topic, and they will actually take us through some of these interactive sessions on how do we appropriately manage them. So we welcome all of you, sir. And to start with, Dr. Sudarshan Reddy, sir, welcome you on board. He's a senior physician in the Hitec City Yashoda Hospital. Welcome you on board, sir. He carries a lot of experience of managing various medical cases in the field of internal medicine, being a senior physician. Welcome.
Thanks, Venkat. Thanks, Venkat.
So Dr. Dilip Nandamuri, sir, again a seasoned senior clinician, being a part of many sessions in both as a public awareness and diabetology and internal medicine. We happen to share many interesting cases in the last couple of months. So we welcome you on board, sir.
Thank you, Venkat.
So Dr. B.V. Rao, who is again a senior young talent in the internal medicine department of Yashoda Hospital. He has been very academic and interactive all throughout the last 7-8 months of our interaction. So we welcome you on board to add the young talent, sir.
Thank you for the kind introduction, sir. Thank you.
So we also probably waiting our Dr. Somnath Gupta, who will be joining. He's again another senior clinician who's been a part and a busy scheduled practitioner. So he will also join us in a couple of minutes probably. And what
sir, I'm available, sir. I joined.
You are available. So we welcome Dr. Somnath on board. Being your busy schedule in this fever season, we're sorry to trouble you, but we're thankful to you that you joined on board. We welcome you on board, Dr. Somnath.
Thank you, sir.
Okay. So I will try to take you all through this. Can you see my slides?
Yes, sir.
Okay. So this is the topic today. So we will take us through to the why we have seen a fever outbreak, which is not an unusual scenario in most of the situations. We see these seasonal outbreaks in this monsoon season, and sometimes we see a pattern like a 1 or 2 years off, and then we see a very huge surge in dengue cases or enteric fever cases, and influenza being an overlap in many times in these seasons. So what I will do is I will just take us through the first slide where we will talk about what has been the pattern of fever cases in our Yashoda group of hospital. This has been the cases which we report to the DMHO. And since from the May, June, July, if you see, in the month of July, we have seen a stiff surge in dengue notified cases. I'm talking about these are the cases which has been either NS1 positive or IgM positive, which are considered to be a confirmatory methods, and then we report them to DMHO, and these are been confirmed cases. And you see from May 10-8, which are commonly seen staggering cases, suddenly shifted to around 10 times of them. And what I'm seeing is this is the tip of the iceberg. So many cases where we do not test them, or they will be minimally symptomatic, or they get symptomatic medicines at home and they get better. But these are the cases which comes to either in the form of inpatient department, get admitted because of some need of the sickness, and these are the numbers. Interestingly, to my surprise, I could find that the enteric cases has been a stiff surge in the Hitec branch compared to the other branches. I have no reason to actually track why this is the pattern, but these are the 13 cases in July, and we had similar 8 and 13 cases in the last 2 months. And this has been a surge since the monsoons in the May month. And this surge has been confirmed enteric cases. I'm re-emphasizing, we do not take any Vidal positive as a enteric fever cases, either a paid Vidal along with a blood culture which is positive for Salmonella typhi are considered enteric fevers, and these numbers has been 13. So we have seen a stiff surge in enteric fever cases. Along with these cases, there has been a overlap where we have seen patients coming with upper respiratory tract symptoms like flu-like symptoms, cough, coryza, high-grade fever, body pains, headache, retroorbital pains, and also used to come with some amount of GGOs, patchy consolidations, and sometimes we see also lobar consolidation. Most of them turn to be an atypical pneumonias and H1N1 being positive in few, and few of them turn to be strep pneumonia and H influenza, and some of them also has been mycoplasma positive. So there was a mix of the 3-4 type of cases which we saw. Interesting to find that in this last couple of months, we also saw a surge in Hep A and Hep E cases. So one of the cases which I present is also been Hep A and Hep E. So this has been a pattern since the last couple of weeks where we have seen a surge in the fever cases in the community and in the hospital OPDs. So to start with, just to make some interesting input to start with, we have a 21 years old student, and this has been a pattern. I don't know, maybe a student's been referred by medical colleagues comes to Hitec. We've seen a series of medical students between the age of 21 to 25, final year, house surgeons on the hostel, taking food outside. And we have seen some other young students between 18 to 20 years who has been hospitalized with us with very high grade fever, 105 or so. And the TLC count initially at the time of a local hospital was 2,400 and platelet count was 28,000. So this has been a common pattern. Now we are seeing when a high grade fever patient comes with leukopenia and low platelets, the common test advised by any local hospital or a clinician in the OPD is a dengue NS1. And this patient had 3 days of fever, so dengue NS1 was positive. But that's not the story which we see in our ICUs or IPDs. So what happens is these patients who have been managed at the home with antipyretics, and most of them do well. They recover with hydration and symptomatic antipyretics and close monitoring. But unfortunately, few of them, I don't know why idiosyncratically or genotypically or phenotypically or a serotype wise, some patients develop into a severe dengue where they start having breathlessness like this patient and starts dropping the blood pressure, and lactates climb to 6 millimoles in the local hospital. And the enzymes initially were what we expect in many of these dengue cases, SGOT, SGPT rising in 300 to 400. And this is the time where this patient was advised to go to a higher center after 2-3 days of management there. And we see this been very common. Out of 10-15 cases, they admit 1 or 2 cases get sick in spite of their best efforts and efficient care. And when this patient reached to us on the day 4 of his illness, he was already on noradrenaline, vasopressin, and his MAP was hardly 50 on a non-invasive blood pressure monitoring, NIBP. And he was need to be intubated before shifting. The patient for the last couple of hours were anuric when this patient was shifted to our center. So when this patient reached to us, we know we are in deep trouble, because when a patient comes like this with a dengue NS1 positive, we have a problems in hand. And believe me, when this patient reached to us in the early hours of the 5th day from a referral unit, the AST, ALTs were in 4,000 plus, and there was a high INR, and platelet count was somewhere 8,000. And at that point of time, the lactates initially were 12. And this poor parents who were dealing with the only son wanted everything to be done in the world, and the CRRT was initiated along with the other invasive ventilatory care and hemodynamic care. But the lactates keep on climbing from 12 to 16 to 24. And within no time to 6 to 8 hours, these patients' pupils were dilated and fixed. And this is not very uncommon scenario in many of you who have been dealing with sick patient like this. So this is a scary situation for any parents, any medical fraternity. Otherwise, a healthy young individual had a fever for 3-4 days back, comes with this kind of situations, and not uncommon. Last year also we have seen few cases like this. We are also this year we're seeing few cases like this. And this is because of multiple organ involvement with a severe dengue hemorrhagic shock syndromes, which are non-responsive to any form of medical therapy, and finally they succumb in a very rapid progression. So this is another interesting case, as I was telling, a young set of students coming to us with very high-grade fever, chills, loose stool, and colic abdominal pain. And these are very typical. If you ask them, did you had a food outside? They said, yes, we had food outside. And some of them, in that particular case, both parents used to be doctors. One was a pediatrician, the father was pediatrician and mother was gynecologist. And you know the anxiety they go through if they manage this boy at home for the 5 days in their local hospital, and then they come here because the fever is not settling. His TLC count initially was 8,200, CRP was high, Procal was high, initiated on all antibiotics possible there, antipyretic on all the supportive care. Being the son of a clinician, has been managed there. He continued to have fever in spite of all those initial antimicrobials. And when this patient reaches to us, his TLC count dropped to 1180, platelet 68,000, SGOT, SGPT in 3 to 4 times. And most of the times, the initial differentials for any such situations may be a dengue in that, and dengue NS1 IgM was sent at that point of time. Along with that, regular blood workup like CBC, blood cultures, urine examination, renal functions, liver functions, and tropical fever was evaluated, including the malaria and scrub and lepto, which were kept on card. On day 4 of this hospital stay, he suddenly developed a respiratory distress in the local hospital and started dropping the oxygenation. And that's when the family felt, no, this patient cannot be managed in the local hospital here with us, needed a higher center to support the patient. And this patient reached to us, and the HRCT was suggesting that bilateral, there was pleural effusions, and there was a collapse consolidation. There was a edematous gallbladder. There was some ascitic fluid. The whole body looked puffed up. This patient received around 8 to 10 liters of fluid on the last preceding 3-4 days. This patient continues to have a high-grade fever, 105 and above, and the patient was escalated antimicrobial meropenem and azithromycin before the patient receives to us as a upgrading of antimicrobial, because this patient was not recovering with 5 days of different antimicrobials with them. So when this patient reaches to us with this history, we kept on seeing the TLC count is started dropping further from 4,000 to 1,000 to 900. The platelets started dropping to somewhere 40,000. And this is the time where we saw that the patient is still spiking fever of 105 on day 14 with an antibiotic of day 8. And at that time, H1N1, COVID RT-PCR, all the film array panel which were sent were negative. Ultrasound abdomen, pelvis rebuild, hepatosplenomegaly with a lot of gallbladder edema and polycirrhosis, but there is no acalculous cholecystitis features. There is no pain or tenderness in and around the gallbladder. And this is the time which we were thinking about the differentials, and we got an information that this patient's initial cultures which was sent were growing Salmonella typhi in both the blood cultures which was sent. So we initially thought, even though this is all, why the TLC count is dropping. So Salmonella typhi is well accepted, but the TLC count of 600 for 960, platelet count remaining low, day by day dropping on antimicrobial, what can be the possibility? So we thought of having a dengue co-infection, and by the time the dengue IgM also came to be positive, we were in doubt whether it is really a co-infection or it is just a mere coincidence with a cross reactivity. And we also were considering HLH and macrophage activation syndrome can be a possibility, which we see with enteric fever or a dengue in many of them. And we sent the D-dimers, ferritin and LDH triglycerides, all were elevated except probably triglyceride, which were borderline with elevated transaminases and also hepatosplenomegaly. And when we saw it was fitting into HLH, and we kept on watchful in this case with HLH, and the hematologist opinion was taken, serial radiology and blood and biochemistry investigation were followed. And over a time with both, we de-escalated to ceftriaxone and azithromycin after the patient reaches us, and with a continuous probably 14 days of antimicrobial therapy with anxious parents, this patient's labs and clinical condition slowly settled. The fever was an issue for a long period of time, which is common in many of these dengue, many of these Salmonella typhi enteric fever, which took almost 10 to 12 days to settle down. And after that, the patient was discharged home happily, and this medical student. This is another case where we have seen a lady, a postpartum lady, 3 months back, he delivered and presented to us with altered sensorium and a high-grade fever and a acute liver failure scenario. I will not just take all these scenarios in a more detailed way. And we happens to see hepatitis A being positive, and this patient was tubed and managed with all the supportive medical management, and over the 7 to 8 days time, in spite of this patient being very high mortality with ALF, or transplant team was on board, and medically this patient was managed for ICP rise, adequate ventilation, bowel evacuation, and all that whatever needed for acute liver failure. And this patient recovered after 7 to 10 days of time and went home. So we have seen a very varied spectrum of cases. When we were speaking to other colleagues, they have seen very sick dengue patients coming to them. Few of them where they actually had the similar kind of multiple organ failure, shock, refractory DICs and death. And they also have seen cases like overlapping with both staph typhus and also leptospira in many of them. So with this background, the whole idea was to start some initial discussion. So I presented few cases. This background, I will take all my clinicians who are there available today to answer all your queries. So to start with Dr. Sudarshan sir. Sir, we have been seeing these cases. I think I presented few of the cases which all of you are involved, either you or Dilip sir or Somnath sir or B.V. Rao sir. But what is your pattern which you are right now seeing in your OPD? Does this fever cases has gone up in your OPD? Is there footfall raised in the recent time?
Yeah, thanks, Venkat. Footfall has been on the rise of late for last 2 to 3 weeks compared to last few months. But the thing is, all our undifferentiated fevers are not non-system specific. Actually, we are not fitting into any of the systems. Actually, initially presenting with 2 to 3 days fever of totally non-specific symptoms, usually body pains, few people presenting with rash and vague symptoms like G. So these are all initially we are thinking it on a viral lines only. But the thing is, after a few days of continuous fever only, we are able to investigate it and diagnose it as a further. But initially, most of the cases are viral only. And most of it has our statistics told that most of fitting into dengue-like illness with viral exanthema and all. And definitely, and we have seen a fever cases which are not responding for all these initial supportive care, which are progressing into second week, where we are testing it. But initial cultures coming late with positive with enteric and all. This is the trend.
So we'll come to those cases, sir. But as far as your concerns, right now, there is a rise in fever cases and the footfall to the OPD has gone up.
Yes, definitely gone up.
And what kind of patients you are seeing? Is there pediatric age group or the adult age groups, or they are elderly, or all of them are coming in a mixed way, sir?
It's a mixed way only, but mostly the college going and middle age group where what we are seeing mostly.
Okay. Younger patients are more than the elderly or?
Elderly. Even more than pediatric group, I feel.
Okay. Maybe pediatricians may be seeing a more surge in their cases. We don't know, but because all 4 of you are from adult internal medicine department, maybe you may be seeing a mix of cases.
Yes.
Dilip sir, coming to you, what are the common diagnosis you are finding? Sir was talking about very non-specific presentation of 2 to 3 not fitting into any system, undifferentiated fevers. And what are you seeing in your OPDs?
Most of our patients are showing either dengue or typhoid, enteric fever. And we are not seeing any patients till now with confirmed malaria positive, either falciparum or vivax. Right now, I didn't have any cases which are confirmed malaria positive. But mostly 60-70% patients are dengue fevers only, and 20-25% is enteric fever. Other 10-15% are like non-specific fever, viral fevers without any positive diagnosis, but behaving like viral fevers.
So to summarize, you're
Yeah,
saying
that's-
there were
I think
cases-
that's and as Dr. Sudarshan told,
yeah, please, sir.
you're not audible. Yeah. As Dr. Sudarshan was telling, we are seeing more in young people, less than 50 years patients or 45, less than 45 years patients are more than elderly patients. And also people with comorbidities like cardiac diseases, kidney diseases, or any immunodeficiency like transplants. We're not seeing fevers in these kind of patients. More of young patients getting fevers is the scenario what we are seeing in this unit right now from my clinical practice.
So what do you think can be the reason, sir? Is this been because the monsoons are there, mosquito bites are the one common reason why you actually get dengue, and maybe
Yeah.
outside food?
Yes. See, all these things are there for everybody. Eating a lot of outside food or monsoons. Everybody, it's same for everybody. But seeing more in young people, one of my probable theory is people are becoming food habits, the stress levels, especially IT people and all the stress levels are very high. They don't sleep well and they keep working for long hours and their diet is not proper. All these things also contribute to less immunity to tackle this viral infection. Viral infection is basically tackled by our immunity. That comes more when immunity is less. So I feel that the whole lifestyle pattern, which is westernizing and a lot of stress with IT jobs and all, I think these are the main contributing factors for less immunity and getting more infections in the younger population than elderly population.
So fever being a very common symptoms where many of us try to be symptomatically manage them at home. Many healthy individuals may not even visit a doctor, and India, unfortunately, they may also go over the counter and take some analgesics and symptomatically manage, and few also abuse antimicrobials. But coming to the medical fraternity, to a responsible physician, Dr. Somnath, does you think that which patients will need evaluation? Does you think all the patient will need evaluation? Which fever patient will need evaluation?
Yeah. Basically, it depends on the symptoms, sir. Initially, when usually at this season, during this last 2-3 months, I could observe a lot of patients coming with non-specific symptoms initially, just with a fever as well as body pains, a kind of mild throat discomfort, and bitter taste and loss of appetite. These are the usual symptoms constitutional symptoms which we see in all the viral infections which usually trend during this monsoons. So when the patient initially present with these kind of symptoms, we usually manage symptomatically. And if the temperature is high grade and with chills, as well as it has been continuing more than 48 hours, with any other symptoms like burning maturation, increased frequency of stools, or increased respiratory symptoms, I usually start evaluating. But initial to 48 hours, if the symptoms are mild and just constitutional symptoms, it is better to manage symptomatically, because 95% of the cases, these are non-specific viral infections.
So you summarized in a way that if a healthy patient without a comorbidities have a constitutional symptoms and probably upper respiratory tract symptoms like flu, cold, and cough, initial 48 to 72 hours symptomatic management should hold good. But if it is exceeding 3 days and you have any other system involvement or inclining towards any system infection, probably you are evaluating them. That's what you carry. So coming to BV Rao, sir, there are many cases which comes to your OPD, and maybe as discussed, we may need evaluation in few of them. But what will be your take? Which patients will really need admissions after a fever evaluation?
Most of these patients who come with fever have to be actually closely monitored, as rightly said by my colleagues. These patients, when we initially assess them, we should be following them also with the same thing and looking for any side effects or complications. When to admit and why to admit depends upon the severity of the illness, the physical condition of the patient, or is he developing any complications relating to the diagnosis that we have in our mind. Suppose like now the common symptoms that if we take, sir, you have discussed about typhoid, dengue or flus as we were talking, we can wait or we can see the symptoms as they are coming. If the patient is developing, suppose we are suspecting typhoid and is developing any complications, complaining of fever persisting for more than 3 days with 100, not responding to antibiotics, getting dehydrated, BP dropping, any complications like severe abdominal pain, vomiting, starting of the medications. These are some things that we need to observe, comparing with our diagnosis, and take a call on admission. It varies from patient to patient because every patient may not develop the complications. They may respond to the initial treatment. So it should be an individual thing for every patient. Patients developing complications are likely to develop complications, are not showing improvement with medications after 3-4 days of treatment should be admitted, especially complications like in case of typhoid, complaining of pains, fever not coming down, or any stomach discomfort, we need to admit. In case of dengue, critical signs, pain abdomen, vomiting, seeing on 3rd day, 4th day, or any bleeding manifestations from nose, gums, or any other side, whatever the platelet is, if there is bleeding, you need to admit them. If hydration is not being taken care of, not able to drink because of vomitings or some other reason, we need to admit these patients. If they are able to be taking care of themselves at home with medications, able to hydrate them, fever coming down after 3 days, yes, we can go slow on them. But anybody developing complications should be admitted.
So very rightly emphasized, these patients need monitoring. Those who will not have access to the monitoring or vigilant care, probably one of the indications which we'll talk about, if somebody has a dengue, if there is no monitoring available at home, no help available at home, this would be under supervision of someone, as you rightly pointed out. And every either enteric fever or dengue, as you rightly pointed out, have their own set of criteria. If they are developing and getting into complicated, then probably most of them will need admissions into them. Sir, Dr. Dilip Nandamuri, sir, there has been a phenomenon which we have been seeing. There is an overlap of cases which are initially coming like leukopenia, thrombocytopenia, and initially we may think this can be a dengue, but later on we turn to be an enteric fever. But some of them also we see dengue being positive. So what is the possibility of this overlap? Is the co-infection or this is a cross-reactivity?
Right now, I have one patient which already discharged, you discussed, where we had typical presentation of viral fever initially. And initially, dengue tests were negative. And then over a period of time, he developed complications like serositis and pneumonia and all. Then blood cultures growed enteric fever. And later, IgM dengue has become positive. It is difficult to tell its cross-reactivity. Maybe a possibility of mixed infection also can be there because clinical picture and labs are initial presentation are coming as viral fever. So we have to keep that in picture. And apart from that, because of this monsoon and water pollution and all, we are getting a lot of enteric fever. I have last month I had that case, and this week also I have discharged a couple of patients who had a mixed infection of enteric and dengue. Initially presented as thrombocytopenia, leukopenia with low platelet levels, not thrombocytopenia, around 1.2 lakhs. And later, after 3-4 days, anyway, when patient gets dehydrated and admitted in the hospital, we send blood cultures, which are grown enteric fever. I'm not talking about viral positive test at all, because we should not emphasize on doing viral at the first week of fever, at least 7 days of the fever. There's no point using Vidal. So all these cases, what I'm talking is blood culture positive, and they responded well after giving ceftriaxone for the enteric fever. So the last 2 years we didn't have any dengue and enteric fevers because of we are very busy with COVID. COVID has taken over all other infections, and this year again we are seeing a lot of dengue patients, and enteric fever also is a very common nowadays. So if you see this, our chart also, the first slide which you presented, we are seeing a lot of enteric fevers in Hitec city rather than other branches.
Any
I don't
reason?
know. Reason, we see the whole people who are working and is we are in Hitec city. The whole population may be coming here to work, and then incidentally, when they get fever, coming to us into the near hospital, which are one of the biggest hospitals what we have in Hitec city, and we are seeing these patients as enteric fevers here. And also, if you see in and around Hitec city, Gachibowli, and all those the outside eateries in Kukatpalli Housing Board, Nizampet, and all those areas, the outside eateries are very much a lot of eatery things are there, and a lot of population who are taking food in the roadside food. So probably that is the reason that we are getting more patients of enteric rather than any other unit compared to other Yashoda hospitals. So mostly Swiggy's and outside food may be the cause. We don't have any other cause for enteric.
Interesting observations, Dr. Dilip, but there are few actually points from my side. We have seen patients who are coming with a diagnosis of typhoid fever with a report of Vidal in their hand. And later on, when we actually evaluate it, turned to be either a dengue or other non-specific viral illness. And the impression given to them is this is a typhoid fever, and they say we have this Vidal test positive and all. So that is a one common scenario which we are seeing, where Vidal test in the first week, as you said, in Indian context, where most of us get exposed to Vidal titers, may not be very significant in diagnosing a dengue. In the other side now, there is another pattern. With the current dengue surge, we are seeing patients who are coming to us with a leukopenia and a thrombocytopenia, typically seen like dengue. And later on, we are seeing the blood cultures being positive for enteric fever, and dengue is negative. So it is just opposite to each other. Initially, Vidal from enteric from Vidal, later on diagnosed to having a dengue or a viral fever. Other way, leukopenia and thrombocytopenia initially diagnosed as dengue clinically, and later on we are seeing an enteric. One typical peculiarity I am seeing is the platelet count in Vidal or enteric fevers. When we see a Salmonella positive enteric fever, is not dropping below 40 or 60. It stays 1.2 lakhs, 80,000 or 60,000. Whereas in dengue, we see a rapid drop from 1.5 to 30 to 10, and then staggering there, and then it will improve. Do you see the same patterns with your clinical experience, Dr. Dilip?
Yes, sir. Yes, sir. Because in enteric fever, we don't see much fall of platelets, and rapid fall of platelets also not seen. But in dengue, at day 4, day 5, day 6, suddenly from a lakh and a half, 1 point, almost 2 lakhs, it will come to below 1 lakh or below 50,000 also. But other thing what I observed is, if you take care of their hydration and other things, right now, last 1 month, I have maybe given one patient only platelet transfusion. Other patients are mostly managed conservatively. The need for platelet transfusion decreases if you manage well with your hydration and conservative measures, like we are doing at our hospital.
So I think that is a very, very important point, which we'll discuss in the later part. Like in the 50 cases, our blood bank is asking, we have hardly used any platelets, so that we will come later. Dr. Sudarshan sir, we have seen different patterns of enteric fever in the last couple of months, and probably you must have been seen in previous times also. And most of our patients, including the patient which Dr. Dilip was talking about, and I have seen a couple of cases, all these patients continues to spike fever for 12 days to 14 days. What is the pattern you are seeing with your experience? How these enteric fever patients behave, and what was your experience?
Yeah, here there are two things, Venkat. One is initially when we see it as a viral fever, there is a cross-reactivity of a dengue patient with initial viral test. So that is also misguiding ones. And one more thing is being an enteric fever, if we treat as a viral fever or dengue, the time is elapsed. So that if you don't give antibiotic for a week or so, by that time, the enteric fever would have increased, the symptoms would have increased. There are two things which has to be judiciously used here. One, if it is like what we usually see in enteric fevers, initial leukopenia will be not so severe as it is in dengue. The initial leukopenia, what I observed in the practice. The platelet count, as you said, it rightly doesn't drop below 50,000, 60,000, and there will be no drastic drop also, as we see in dengue. So that is the time where we have to decide and send the cultures initially before starting antibiotics. So in that case, it is the duration of symptoms once we start antibiotics like what ceftriaxone. The duration is like maybe a week or so, most of the cases. But what as a tertiary care, what we are getting, the time 10 days we were outside, given quinolones and rest of other antibiotics are not adequately given, inappropriately taken. Those things, but what we are seeing is more than 2 weeks, 3 weeks of fever also we have seen recently or last month also. We've seen a fever of more than 20 days in spite of antibiotics, which were actually, you were also involved in one case. We thought of escalating, and then depending on the symptoms and the lab values, we de-escalated actually to ceftriaxone and azithromycin. This is the things. How initially treated enteric fever response is totally different with that late use of antibiotics. If you use late, the symptoms, it is taking duration is more than 2 weeks also. But if you diagnose early and start, I think maybe week or 10 days is ideally what we have seen.
So your point valid here, sir. Most of the situations when we actually see these enteric fevers, either they are confirmed by a blood cultures being positive, or you have a strong clinical suspicion where there is a gastric symptoms like abdominal pain, loose motions, and followed by chills and rigors, fever spikes, which kept on with an exposure to the external food.
Yeah.
And then
one more thing, Venkat.
There were some comments that after 1 week, as rightly pointed out, if you have a paid sera, which suggests a rising titer of Vidal,
yes,
that may give a inclination, even though we now, as a standard of learning, we say Vidal test in Indian context cannot be considered as a diagnostic tool, but along with the clinical context, because as you said, many of these patients receive antibiotic before they come to you. And partly they may be getting some of the quinolone, some of the combination of antibiotics, and we don't, it is not uncommon to see also rapid changes of antibiotics. So cultures may be negative, but if you see a typical pattern, as rightly pointed out in your case, a young boy, 20 days of fever, roaming around with different antimicrobials, gives a very typical history. He had an outside food exposure and monsoon period, followed by a couple of days of GE symptoms, abdominal cramps, diarrheas, loose stools, then followed by chills and rigors, received here and there 1 or 2 doses of antibiotics, kept on with paracetamol, and then we had a very high titer of vitals, followed by rising titer of seropositive, and blood cultures were negative. So we thought probably we are dealing with an enteric fever because of multiple antibiotic exposure. The cultures are not holding, and we stuck to that. And one of the interesting point is all these patients, in spite of appropriate antibiotic, both with ceftriaxone and azithromycin, in my observation in the last couple of months, all of them are taking 7 to 10 days for defervents, and which is a typical description in enteric fever. But how do we actually keep confidence? Because the family asks you questions. All of us, including Dr. Dilip sir, we all were been questioned why my son's fever is not getting better. If we have a blood culture positive, or we see other organs are improving, as in your case and Dr. Dilip sir's case, the patient's clinical condition started improving, platelets started improving, LFT settled, leukopenia got settled, his well-beingness settled, but only thing which is lagging behind was fever, which took time from 7 days to 10 days. And I think, as all of you suggested, we need to keep our nerves holding on. If the patient is improving, clinically there is no new organ dysfunctions or deterioration, I think that is the only way where we can handle this, sir. So coming to the next part, which was interestingly debated earlier also, So, Dr. Somnath, you have been seeing a lot of OPD cases recently with fevers. What kind of dengue pattern you are seeing? What are the atypical dengue presentation? What is the typical dengue presentations you are seeing? Dr. Somnath, can you hear us? We'll come to Dr. Somnath later. Bivira sir, there was a very interesting discussion, and Dr. Dilip has pointed out that he hardly used any platelet transfusion. Even the patient who are ICU admitted, even we are showing that we have around 40-50 dengue cases with IP admissions. We hardly required any platelet transfusion, maybe probably very few single digit numbers. So what is your take? What is the trigger for platelet transfusion? And what will be your experience in giving platelets, not giving platelets, the anxiety related to the family, and what is your take on that?
True, sir. In platelet transfusion has become nowadays like people are coming and asking directly, platelets are dropping, we need platelets, we want to give platelets. What can be done to increase platelets? And all sort of questions, especially the diagnosis of dengue. As rightly pointed out by Dr. Dilip, if you remember, we have also not transfused platelets for a patient in ICU who had 10,000. And not to forget, one of a doctor was also admitted. I think Dr. Sudarshan would remember. We have not transfused platelet in spite of being anxious of taking it. So generally, sir, one thing we need to look at when we are thinking about platelet especially is it should be reserved for those who are having severe bleeding or severe thrombocytopenia who are at risk of bleeding. We should understand another thing here is platelets alone are not the reason for bleeding. In dengue patients, vascular permeability and coagulation problems are also there. So platelet transfusion is not just the solution. Now, if you go back and look at the recommendations also, sir, in 2019, the WHO recommendations that we see, they have said if there is no bleeding risk, and even if the platelets are 10,000, we do not transfuse platelets. So most important in dengue at least is to know the acute phase, complicated phase, and the recovery phase. Usual pattern in dengue, first 3-4 days is the febrile phase. The patient will be having fever without any rash or itching, or dropping platelets may not even start during this febrile phase.
True.
It is all after this febrile phase, the 3rd, 4th day, once the fever comes down, that we start seeing the platelets drop. Most of these patients, once the fever comes down, they think, we are recovering and we are good. And they miss follow-ups and end up directly into the hospital emergencies. So when you follow up this, we need to also counsel them and tell them so that it will be reassuring for them and they not keep on asking about transfusions. So my take on this would be simple, sir. Only reserve it for those who are having severe bleeding from the gums, urine, or who have rashes, pedicle, this thing, or who are having critical thrombocytopenia that is less than 10,000. There also, with caution, we can still stay. Usually, in my practice, I have been seeing in the last few years, sir, day 8, day 9 is a time when usually platelets start recovering. When the critical phase also ends and the platelets start improving. So I would not transfuse platelets to a person on day 8, day 9 illness who has been 10,000 if it's not bleeding. We can be watchful even there. But most important is the patient anxiety, as you are rightly mentioning out counseling. We need to give them that reassurance and take it accordingly. But I can still say it depends on the number of days the patient has been suffering with that illness and on what day is this platelets in a critical range.
So I'm actually very overwhelmed by the response from all the 4 of you, being the part of the team. And I have not seen any of you recommending platelets even in a critical stage. Probably less than 10,000 with a bleeding tendency was the only indication where many of you advised. And probably that is the message you wanted to give. Platelet transfusion also carries a risk of platelet transfusion related complexities, including a TRALI, including a cross reactivity, including delay in recovery, and including all the possibilities of a transfusion related concerns. And many of the times, as all of us know, dengue-related thrombocytopenia is a self-limiting event. It is just the matter of time that the platelets will refer back. And as you said rightly, the WHO doesn't recommend platelet transfusion for any cutoff. Some of the Indian guidelines recommend a cutoff of 10,000 because of our context. But they say if you have a patient who is bleeding with a DIC and thrombocytopenia, probably your FFP's replacement, factor replacement may be initial choice over a thrombocytopenia, and hemoglobin supplementation in the form of packed cells may be helpful, and most of the patient may drop. Yes, sir. You have a point, Dr. Dilip.
No, not a point. I have a chat message telling that few people are telling it's very feeble voice. They're not able to listen. Just check once. I'm able to listen.
I think the problem is from their side.
Yeah,
so,
okay.
Rightly pointed out, Dr. Venkatesh. So we will go to Dr. Somnath. Dr. Somnath, we were discussing about the common pattern of dengue. There were some questions in the chat box saying, can there be a what you say, the tricky sore throat? Can there be any dry cough in dengue? So we just wanted to ask you, what are the kind of patterns of dengue fevers you are right now seeing? You have been a busy seasoned practitioner right now in OPD. So you reached home late. So what is the practice you are seeing?
Usually everyone knows that dengue has a classical presentation, that it starts with a very high grade fever with chills, then has a constitutional symptoms like body pains, weakness, and a headache, excruciating headache, and bitter taste and loss of appetite initially, followed by patient presence with some abdominal pain, mostly right hypochondrial pain, and vomitings, as well as increased frequency of semi-solid stools. This is usual presentation, and after 4th, 5th day, the fever subsides and patient presents with itching as well as cough. These are all the signs which we know that usually it is a classical dengue presentation. But this season, I could see few atypical presentations also. Patient initially started having presentation of abdominal pain, diffuse, and then presented with vomitings. After 2-3 days, the patient started having fever. These have been seeing almost like out of every 4 cases, I've been seeing in one case, like 1 in 4. And there are few presentations like patient just having fever for 1 or 2 days and all the symptoms vanishes and the patient doesn't have any itching, any kind of vomitings or any kind of abdominal pain, loose stools. And these kind of mild dengue presentations are in like almost 75% of the cases presented this season. So almost I could see just a mild presentation of body pains, weakness, fever, and headache for 2 days. And after that, patient is completely asymptomatic, and they've been monitoring the platelets as well as WBC and PCV hemoglobin. I could see the trend also, the platelets just coming up to 1 lakh and it's been improving, and as well as labs like WBC coming around 2000 and started improving on 4th and 5th day. And hemo concentration as well as PCV rise is not very much. And psilocybin also I couldn't see much in this season. But definitely there are few cases I could report where I could see there are complications like liver involvement, hepatitis, and as well as few presenting with severe acute gastroenteritis and few severe polycirrhosis in terms of continuous cough for around 1 to 2 weeks. So, but most of the presentation I could see there are mild dengue patterns with just a fever and as well as constitutional symptoms for 2 to 3 days, not more than that.
So thank you, sir, for that. Dr. Dilip, what will be the warning signs of dengue? We are no more saying dengue hemorrhagic fever. The terminologies we are saying dengue fever, dengue fever with warning signs, and the dengue shock syndrome. So what are the things you are saying? Warning signs are a severe dengue signs.
The warning signs, what first is clinically we have to evaluate what is the warning signs. If patient like Dr. Somnath told comes with breathlessness, abdominal pain, and abdominal bloating or cough, all these things may be related to polycirrhosis, which develops around 5th to 7th day of fever. So these are the things that is telling us there is a third space loss. How much first is we are not to evaluate. And depending on what is the third space loss, the complications may set in. Here, for dengue, we tell always to give a paracetamol, fluid replacement is a mainstay of treatment. But when a severe third space loss is there, then it has to be in a different way. And it's a more coordinated and guided way we have to give the fluids. Just giving fluids will not help. It may be overload also. So first thing is a patient developing breathlessness. Any simple abdominal pain also should suspect that he is developing polysinusitis, breathlessness, cough, and abdominal pain. And third thing is severe body pains not resolving at 4th, 5th day also, saying that he still is not in a recovery period. Headache, body aches, leg pains, and all those things. And also when we do a routine investigations like LFT and creatinine and CVP, we may be seeing a rising pattern of liver enzymes and creatinine, which is telling that this patient is a probable case of going into polysinusitis and multi-organ failure. And we have to treat this patient very closely in ICU setting so that the fluid management and BP management should be taken care. Otherwise, they will shut down the kidneys and go into multi-organ failure and death. So these are the early signs. First is clinical signs and symptoms which we need to take, correlate with your basic blood test reports. This will tell us that how this patient is going to progress in next 2-3 days. And accordingly, we have to plan treatment for this kind of patients.
Very, very rightly emphasized by you, sir, saying ki abdominal pain. Many of us may get misleaded. If a severe dengue patient, a high-grade fever patient with abdominal pain complaints, we have seen the rapidly deterioration can be a very common phenomenon. And as you rightly said, other than that, a capillary leak phenomenon leading to hypoxemia or a patient leading to LFT derangement, severe thrombocytopenia, coagulation disorders, organ failures, and hypertension. These are probably our indicators. Any lights on the ratio which we saw SOC index or your systolic BP, your heart rate by systolic BP ratio nowadays we are seeing, or a your pulse pressure or the gap between diastolic and systolic pressure we are taking, Dr. Dilip?
See, what I see is we have a lot of equipment and parameters and scoring methods nowadays available to anticipate the complications which are coming. So first thing what we do in our setup is if we clinically during our rounds or when we see this patient, we anticipate these symptoms. It is always better to first shift him to ICU care, where we have to periodically check what's happening with this patient and put the scoring, measure the map and all these things, and then give the fluids. Just ordering some fluids or some medications in the ward may be detrimental for the patient rather than help. So it needs a more coordinated care with the critical care team also to give a better treatment early so that he'll not. Some people say he's still okay. Why do we want to shift to ICU or critical care? But what we need to anticipate is we should not make them more sick and then hand over to a critical care guys. Rather than that, hand over early, take early call on shifting the patient to more close monitoring and management so that his hospital stay and cost will reduce and complications will reduce.
So early appropriate management, close monitoring may save this patient from further rapid deterioration.
Kola sir, sorry to interrupt. Check your volume once. Your audio is a little low.
To you also?
I can hear okay.
Okay, is it better now?
Bit louder. Okay.
Better?
Yes, better.
Yeah.
Okay. So coming to Sudarshan sir, so the most common complexities which we face with the dengue patient is capillary leak syndrome. As everybody was trying to point out that. See, the treatment of dengue fever initially was symptomatic. It is just hydration, rest, and probably antipyretic, and keep closely monitoring them for any rapid deteriorations. But the capillary leak syndrome adds new problems to us. One side we say give volume, and after a few liters of volume, if your capillary starts leaking in the critical phase, as Dr. B.V. was suggesting, after the febrile phase, when you enter into the critical phase, your capillaries may start leaking, and whatever crystalloids you're giving into the IV form may leak into the different systems, and or sometimes without even giving our IV fluids, they start leaking and your intravascular volume gets depleted and you see a hematocrit get rising. So what is this capillary leak syndrome? How do you manage your cases with capillary leak syndrome?
Capillary leak syndrome, usually it's now can say it's a critical phase of the dengue illness. The thing is, usually we see capillary leak around 5 to 6 days of the day of illness, 6th day of illness. The time when capillary leak sets in, we definitely see a rise in hematocrit, and there is a definite hypotension. So these two things. And one more thing is LFT along with rising transaminitis, there is a definite hypoalbuminemia. And one more thing, hypoalbuminemia without any urinary loss, no albuminuria. This is where these three things we have to look into. And depending on the fluid, whether to give, if it is capillary leak is not so severe, and the febrile phase itself, it starts, that is a tricky situation where we have to judiciously use fluid. But after febrile phase, it's a rising hematocrit and hypoalbuminemia, that is where we have to cut down fluid, and definitely restrict the fluid. That is the thing. And there is no definite studies where which patient goes into capillary leak syndrome, which patient doesn't. So only thing, as Dilip rightly said, we have to closely monitor, or more than closely, we have to counsel patient that anytime we may have to shift depending on the rise in hematocrit and hypoalbuminemia, transaminitis. These things, along with transaminitis, there is a definite hypotension, and what I see in my case is the definite pulse pressure narrowing is one of the best indicator for the impending bleeding. Also, what I have seen in my clinical practice, definitely a lot of patients will have a very narrow pulse pressure. So that also one of the we have to closely look into.
I think these are the few maybe thumb rules which have been used in many settings, like SOC index, your heart rate divided by systolic blood pressure rising more than 100, 130. It suggests you're going towards a possibility of a SOC, and the other thing, you're narrowing the pulse pressure, and probably you see capillary refill time, other indicators which you do see, cold, clammy extremities. But rightly you pointed out, sir, many of these patients who initially saw the rising hematocrit and initial leak of capillaries, and they respond well to the regular crystalloids, that any of your balanced crystalloids in the form of ringer lactate or any balanced crystalloids. But at a point, after some times, once you actually try to resuscitate adequately, may vary between 2 ml per kilogram in each hour to 10 ml per kilogram, depending on the SOC and the hematocrit rise. But after a certain period, if you give more fluids, we see them going into hypoxemia, they leaking into the capillaries, leaking into the different cavities. Ascitic fluid goes up, pleural fluid goes up, pulmonary edema sets in, and sometimes we also see ARDS kind of picture in lungs. And these patients, as in our case, also shows some amount of cerebral edema, and they go into an altered sensorium. And in no time, they actually cone to an extent that if you take a CT scan, in our case also, there was a severe cerebral edema compressing a brainstem. No time they herniate and they die. So the discussion in many of the literatures, when I was reviewing, can I use a colloid? So in any of you have any viewpoint? So there were different colloids. Hydroxyethyl starch was nowadays not been commonly used. Dilatins were not used nowadays. And even albumin has not been into a common practice. We have few studies in pediatric age group where they tried to build this oncotic pressure with a few of this albumin as a natural colloid. Dextran, some percentage of dextran has been suggested by UpToDate with some references in pediatric age group. Any of your comments or any experiences you want to share in this context? Can we use colloids in this special context?
Colloids is definitely a controversial role when compared to crystalloids. But I have seen in few cases using albumin when the patient requires a large volume, it's a replacement. So adding albumin with the crystalloids when the patient has severe hypotension as well as more of thought spacings. In the scenario, I feel albumin can be a better option adding to crystalloids.
Any points from Sudarshan sir or anyone else? Severe
Yeah,
Rightly pointed out by Somnath, during the critical phase like severe shock with organ failure and all, if you look at the benefit and risk ratio, definitely we can try giving albumin. That is one thing. I have done that in 2 patients initially when I saw severe shock leading to organ failure, not responding, little more fluids, the pulmonary complications would worsen. So we thought we will give this albumin and FC. That worked out actually. So I have a very little experience, but that is where I saw 2 cases.
One more point to add is that's a very to take this decision or to add hypoalbumin and prescribe is a very short time because whether patient can improve or deteriorate, that is the time where you have to. So we have to exactly point the time where you have to give albumin and because improvement also very rapidly improving once that illness recovery phase will also be very fast. So the time where you decide is very important to give albumin and so. But I agree with Somnath giving with albumin and crystalloids.
So as we all understand, there is definitely a controversial state at this point of time to actually talk about the appropriate indications of these colloids, particularly when we are dealing with both hydroxyethyl starch and gelatin has gone through that different complications, including acute kidney injury or different things. So now we don't have any synthetic colloids available except probably albumin. And I was surprised to see dextran on the flowcharts of the up to date, where it writes about not to use albumin, but if you can consider it dextran. And when I saw the references, they've been dragged from some pediatric studies and some other studies. But when I actually searched the literature, there were literatures which divide in its position, but few of them said, yes, in some of the pediatric age groups also, they considered using albumin in a very maybe a very vigilant way. The complexities with which we see albumin is it can be a very toxic to pulmonary system. You have a pulmonary leak already, pulmonary edema, you add albumin, it can deteriorate your ARDS or pulmonary edema. And it can be also detrimental in raised ICP patients where you have actually already a cerebral edema. This can create a little problem. But yes, in other situation, if I don't have that and I am managing well, maybe I can skeptically consider that. But the initial choice of fluid is a crystalloid and is a balanced salt solution. And these all can be only used when your crystalloids fail and you are not able to use crystalloids and your patient are hypotensive and in shock and you are using only a vasopressors and you wanted some volume to be developed. Dr. Somnath, what is your take on the acute liver failure? Last year, when I was in the previous unit of us, we have seen a very good number of cases, sick patients who are coming to our hospital were having acute liver failures. They come within a couple of days, they actually saw a very rising titer of liver enzymes, and then in no time they succumb to the illness. And also anyway, the end of this all pathways is DIC, which we see. So what is your take on that?
Yeah, basically this season I could report only
Switch on
1
your
or 2
cameras.
cases. Yeah, this season I could hardly report 1 or 2 cases of acute liver failure, mainly viral induced. One is I saw hepatitis E patient and one more in dengue, but luckily both have been recovered. Both had a phases of elevated bilirubins as well as elevated SGOT and SGPT levels, transaminitis, and a hypoalbuminemia with ascites as well as elevated prothrombin time. So it could classically fit into acute liver failure. One is with hepatitis E and one is with dengue. So hardly we see transaminitis, mostly we see transaminitis in dengue, but hardly we see liver failure in dengue. But one case was reported with me, but both luckily they didn't go into complete liver failure. They recovered, but it took some time. Definitely there was a lot of morbidity in such patients. It took around 1 week to 10 days of hospitalization in ICU and 1 week in room stay. But finally, I could see they recovered. But regarding disseminated intravascular coagulation, I could report one case of dengue who lately presented to me around 10th day 12th day with low platelet count. And when I saw there was a dengue reported and was like a clear trend of dengue where the patient had a gallbladder wall edema with a protein loss in the urine as well as transaminitis and a low leukopenia and thrombocytopenia. But he presented with secondary bacterial infections where he landed into disseminated intravascular coagulation. I could see like all the classical signs of disseminated intravascular coagulation, like platelet count improved and after that it fall. And finally, we couldn't, there was no time to recover the patient. The finally patient succumbed. So this was my experience in like this season with acute liver failure and DSC, mainly in viral infections.
So there was also a question related to that in the chat box, which is asking, do you see hepatitis in dengue fevers? Yeah, I think you answered that. We can rarely also find this sick group of patients who can land up into a severe hepatitis leading to acute liver failure, even though it is not in all patients. The patients who come to the tertiary care, intensive care unit, some of them actually present to us with acute hepatitis, and the enzymes were elevated to maybe 3,000 to 4,000, and they go into encephalopathy, and then they go into a raised ICP, and very rapidly they deteriorate. And as you said, luckily few patients, if they don't progress into that severe form of encephalopathy and slowly recover from there, are the patients who are lucky. But the dengue hepatitis is a known phenomenon, and it is one of the poor prognostic marker, and you need to be very careful in them. And there were many reports of trying different modalities, including plasma exchange, in saving this hepatitis with dengue patients with acute liver failure. There were questions related to your topic, Dr. V.V. Rao. There were questions related to HLH. I wanted to ask you that. See, many of these cases where we know by a normal disease process, we see leukopenia and probably thrombocytopenia as a normal phenomenon, but we also see both dengue and the enteric fever or any other bacterial and viral infection can also cause a secondary HLH. And this secondary HLH, when do you suspect? What are the clues to actually guide you that this is a HLH?
HLH is a very rare phenomena, sir. It is not that we are not seeing patients, but it is not a common condition. As we all know, it is overfunctioning of the immune system, especially the T lymphocytes and macrophages, which cause this. And we have seen such HLH cases in typhoid and dengue also. It is rare in them though. And it is not common to happen in the first initial week time, because for this trigger, for the HLH to develop, will require a cytokine storm. It is during the complicated phase, if in case of typhoid, if it is not treated properly or undertreated, not responding to antibiotics, developing complications, is the time when cytokine storm leads to this overstimulation of the immune cells, especially the macrophages and T lymphocytes, leading to this immune cells affecting the other organs, causing multi-organ failure, with the criteria, as we all know, for the HLH to happen. It is not definitely early in the disease, it is late in the disease when cytokine storm takes over. So as we all know, the criteria for this diagnosis, it is not just leukopenia or thrombocytopenia. Fever is most important, as first it was described in 2004, and the modified criteria was given in 2009. It says you need to have fever, splenomegaly, hepatopathy, and thrombocytopenia and leukopenia less than 1 lakh and less than 1,000 as mentioned. Along with this, they can also have raised triglycerides, reduced fibrinogen, CD25 marker, which can be increased, that is a IL-2 receptor function thing, and the natural killer cell function being reduced. So you need to have it. The first 4 is very important, that is fever, splenomegaly, hepatopathy, and leukopenia with low platelets. Any of these with happening after treating the patient for more than a week and not responding, then we need to also consider this. It is mostly a diagnosis, it is not a diagnosis of, in the initial phase, it is like a diagnosis of exclusion. Later in the course, when not responding, we need to keep this in mind. But it is very important to keep in mind because the treatment for this is steroids. and whenever fever is there, we think twice of giving. So we need to be very carefully looking into this. And diagnosis is a suspicion. Importantly, is a diagnosis of suspicion. We need to consider it if it is not improved. The best way and the most important thing I forgot to say in this criteria, we need to prove phagocytosis either in the lymph nodes or in the bone marrow or in the skin, which is 100% specific to this.
So you rightly, very eloquently put across, sir. If these patients who are generally after a febrile phase of 7 days, generally dengue patients should go into a febrile phase or a critical phase. If the patient continues to spike fever in a dengue diagnosis after 7 to 10 days, with this all like a leukopenia and thrombocytopenia, which is persisting with, as you said, splenomegaly, hepatopathy, and raised inflammatory marker, probably those are the conditions where you keep a suspicion. And do you think a marrow is a must or is it additional?
The criteria says it has to be done, sir, but if the suspicion is strong and not responding, then we'll have to consider, but I would never say it as a first thing. Even lymph nodes are not a bad choice. Even lymph nodes can be FNAC of those.
Not
can
just
also
marrow, but lymph nodes can also
lymph
be.
nodes also can be done. Not always marrow.
And interestingly, we have primary HLH and secondary HLH. These are all considered to be a secondary HLH with dengue or some bacterial infection, including enteric fever. Also, we have seen some patients landing into severe HLH, needing therapy for them. And as you said, ferritin has been one of the marker which has been used in them, along with triglycerides and others. And the interesting therapy, which is, as you said, steroids. And if in a severe form of primary HLH, etoposide has been used. But the problem with primary HLH, etoposide can be used. But the problem with etoposide is many of our patients, we have to differentiate between whether it is an infective or non-infective. And in an infective situation, when I'm in doubt, etoposide use can be a challenging. But we had a couple of series cases where there was a suspicion of HLH not responding to steroids. Etoposide made a magical recovery. So if in a situation demanding, you should not hesitate to consider etoposide as that. There were some chart questions which I will take quickly. We can go through and then can. So there was a question with that typhoid dot. Can typhoid dot be used as a test for diagnosing enteric fever? Asis, as Dr. Asis is asking, anyone who wants to take typhoid dot IgM?
You're not audible, sir.
Typhoid dot IgM.
Typhoid dot IgM can be used along with cultures, but the thing is, it only shows Salmonella typhi. Other forms of enteric like typhoid, the paratyphi, we can't get it. Only Salmonella typhi we get it. We can't tell it as an enteric fever diagnostics. Only for the Salmonella typhi fever we can, but other species we can't with typhi Ig.
So it can be used as a screening tool to initially, but it cannot exclude or confirm a diagnosis in that situation.
Yes.
So there were questions related to ceftriaxone is known to cause thrombocytopenia. Is it advisable to start ceftriaxone in dengue patient with suspected secondary infection? Anyone wants to take?
Yeah, right. Okay.
Go ahead, Venkatesh.
Yeah, so ceftriaxone is, just reading the question out again, ceftriaxone is known to cause thrombocytopenia, but is advisable to start ceftriaxone in dengue fever with suspected secondary infection. Yeah, so basically suspecting secondary infection initially in the initial phase of dengue, we need to be very cautious, definitely, because viral fevers do not require any antibiotic. Exactly. So what you should first be looking at is fever in dengue fever to subside will take at least 4 to 5 days. Okay, is it secondary infection? You need to look at two important things. Any bacterial infection, the patient will be toxic. Look at dengue fever, patient will be toxic during the phase of fever, but when the fever subsides, he will be little active. So whenever starting an antibiotic, and if you're 100% sure it's a secondary infection, then only start an antibiotic. And coming to the point of ceftriaxone causing thrombocytopenia, we have been using thrombocytopenia a lot. So thrombocytopenia in dengue starts during the critical phase, that is after 4th, 5th day. It does not cause much thrombocytopenia, but it is a basic antibiotic. Rather, I would give ceftriaxone rather going to cefoperazone, sulbactams, or piperacillin. This is a basic antibiotic. If that is a doubt or if a secondary infection is suspected, better to give ceftriaxone and monitor closely if you have.
I think that is the most commonest used empiric antimicrobial when a patient comes for an admission with a tropical fever suspicion. I don't know whether it is an enteric, I don't know whether it is scrub, or don't know it is a dengue, and patient needs an admission because of his sickness. A combination of maybe ceftriaxone and doxy is the most common combination which even guidelines suggest. And but once, as you rightly said, dengue is confirmed and you ruled out other possibilities, you don't need an antibiotic, you should discontinue all the antibiotics. And when the question comes, ceftriaxone precipitating thrombocytopenia, I think we have live examples with both all of you that a patient with an enteric fever comes to us with a thrombocytopenia and we use ceftriaxone and azithromycin and the patient recovers. Because the thrombocytopenia is not because of ceftriaxone, it is because of enteric fever. You treat enteric fever, the patient responds. And ceftriaxone and probably azithromycin will be the combination which many of us will use. There is a question to you, Dr. Somnath. You said cough can be a phenomenon. There is a question, can polyserositis is the cause for the cough or there are other causes for the cough?
Yeah, definitely there are as I said prior, these viral infections, mainly dengue, there is a polyserositis, mainly we see in 5th, 6th, 7th day, where you could see there's like a mild to moderate pleural effusion that can stimulate dry cough. And in these kind of viral fevers, there is a secondary bacterial infections adding up, and these can also cause respiratory tract infections and which can also give symptoms of cough. So mainly the primary cause which we see in few patients this present with the cough around 4th to 5th day, that is more of dry cough or irritant cough that we see because of polyserositis.
Okay. So I think we had a good chat of around 80 minutes. I think we have few questions. I think many of them are common. So we have gone through more than 100 or so in the live viewers, and maybe it will go to few thousand by a couple of days. So I thank all of you, and I wanted a final comment from each one of you to wind up the session. There were many heterogeneous combination of clinicians who are watching you, all of you sharing your experiences, comments. Sir, final comment, Sudarshan sir, how do we tackle this fever situation? Any take home for the clinicians and families who are looking at this program?
Healthy lifestyles, like from starting, as everybody knows now, from hand washing to mosquito nets, mosquito repellents, all these things, all household practices. And I think by this time, because of luckily COVID has taught very well. So everybody is knowing, and that's the only thing to avoid mosquito bite, to avoid dengue, and good clean hygiene, properly cooked food to avoid enteric fever. So these two things. So
any comments from Dilip sir for the clinicians? How do they evaluate and care the patient?
See, if you talk about, sir is talking about dengue, malaria and all, mosquitoes. Let me tell about enteric fever. Enteric fever, first thing is water hygiene, food hygiene. We all see that we are taking care of that. And sometimes we say that we have gone to very best restaurants and then they got a fever. See, eating hot food, drinking good water is one part. And food handling by the cooks or the people who are serving us also can cause enteric fever. And if the plates and utensils which are not cleaned properly also can cause enteric fever. And last but not the least is the best source of best place where enteric can sleep happily is your ice creams. Those are the sources for enteric fever also.
Eggs, poultry products and all
yes.
that. Yes.
So we have to be very careful on what we eat during the monsoon season, so that you will not avoid hospitalization and difficulty, all these things.
Dr. Somnath.
My take-home message in dengue, mainly in dengue, sir, regarding everybody thinks about the platelets, but the main point of interest is always hematocrit and hemoglobin concentration rather than chasing the platelets and thinking about transfusions. So always be better think about hematocrit and as well as PCBs as well as hemoglobins rather than thinking about platelets and like more of fluid management rather than platelet transfusions.
Okay, very well taken. Dr. Venkatesh.
So as my colleagues have already told about the prevention part and all, and most of the participants, if I see are doctor students, most importantly, I would like to tell when history is the most important, any infection, history is the most important. And coming to fevers, you need to look at the day of illness and also when you are doing what test. Most as to start with, when Dr. Venkat was telling, we get dual infections. Most of the times patient come with a typhoid report. If you see, most of the time viral test is done within 5 days of the fever on day one itself. So I would say every test has a particular time when it has to be done. Like in case of dengue, NS1, IgM, IgG. Same in the case of typhoid, when to do a Vidal. Really is Vidal important, type P, IgM or cultures. So what I'm trying to tell is history, day of illness, what day you are doing the test, and the management. So this is very important. This is my closing thing.
I think that was another question. I think some of the audience and participants were asking, how do we categorize and investigate? Most of the healthy, otherwise without comorbid patient with upper respiratory tract influenza-like illness may not need any investigation except symptomatic care at home. But those who are at high risk comorbidities and having fever more than 72 hours with differentiated organ involvement probably are the patients who need more closer evaluation and further. But beyond 72 hours, probably all patients need some or the other form of follow-up and a visit to this expert panelist to probably to guide them. And I thank all of you for your valuable time and a wonderful discussion, sir. Sudarshan sir, Dilip sir, and Somnath sir, and Venkatesh sir. We thank from our bottom of heart to be a part of this program and making this program a learning experience for all of us. Thank you all, sir.
Thank you, sir.
Thank you, Venkat. Thanks for that.
So I thank all the participants who has been a part of this program and made it interesting. And I conclude the session. Thank you all.
Thank you.